Welcome to NMDP Black Blood Hills. NMDP operates the National Registry of Blood Stem Cell Donors. Tune in as I share tools and resources on ways you can be a change agent and save a life in your community. Welcome to Black Blood Hills. I'm your host, Tamara Weston, and today's episode, I'm going to be speaking with Dr. Margot Rollins, who is a pediatric hematologist-oncologist who practices at Children's Healthcare of Atlanta, and she's going to talk about how she works with and takes care of our most precious prizes, our baby infants and toddlers. Welcome, Dr. Rollins.
Thank you very much.
How are you?
I'm doing well. Survived the weather outside.
Nice. Thank you for joining us today. So happy to have you here.
Thank you. I'm honored to be here.
Now, while I gave your title, I know there's so much more behind it.
Yes.
So I'm going to ask you to tell us a little bit about yourself.
So I actually serve in two capacities at the Children's Hospital. I am a board-certified pediatric hematologist-oncologist. So that means I specialize in treating children with cancer and blood disorders. Specifically, I treat children with sickle cell disease and other benign anemias. I also am the medical director for transfusion and apheresis at Children's Healthcare of Atlanta. That affords me the opportunity to oversee how blood products are acquired and distributed to those patients that need transfusion. And then the apheresis side is when patients need therapeutic apheresis, let's say sickle cell patients who get red cell exchange chronically. We oversee that. And we also oversee blood stem cell collection for patients who may need it for transplant, either for their own transplant, so that would be an autologous stem cell transplant, blood stem cell transplant, or it would be allogeneic if they're donating their blood stem cells to somebody else.
And that is why I wanted you to go a little bit deeper, because I don't think I gave you enough credit by just calling you a pediatric hematologist-oncologist. So thank you for sharing that with us.
Absolutely.
And, I think when we talk about babies, when we talk about infants, and when we talk about toddlers, our hearts always seem to expand, right? We always want to just make sure that they're taken care of and loved and just are in good health. When you work with babies, how was it identified that they have a blood cancer or a blood disorder?
So it can be identified in a variety of different ways. In the United States, we do something called a newborn screen, and the newborn screen is done across all 50 states. Okay. There are certain disease processes that we screen for in every state. Sickle cell is one of those, cystic fibrosis, often things that we think of if we know that they have it when they're very young or when they're first born. We can intervene so that they can have a longer lifespan. So newborn screens are one way. The other way that we can screen is your children go for their regular checkups. And when they go for their regular checkups, your general pediatrician is going to do a physical exam. They're going to check your baby's weight. They're going to check your baby's head circumference. They're going to ask you how the baby is feeding, and they're going to get labs at some point. Generally, around 12 months, we get screening labs. So we check to make sure that babies follow a normal growth parameter, and when something looks off, either you're growing too big, like a head is growing too big, then we can go down the line of, do you have a brain tumor, or is there some obstructive process going on in your brain? Or if we're doing your exam and you have a big liver or a big spleen, or your baby looks pale and they have abnormal lab values, then we can go down the route of, do they have leukemia or some other bone marrow disease process?
So is it, when we talk about mandatory testing, because you said that it can be detected like at your annual visit or doctor's visit. So is it not always detected as a newborn? Can it develop after?
Yeah, so it really depends on what disease process you're talking about. There's some disease processes like sickle cell and thalassemia that you are born with.
Okay.
When we start talking about cancers, those are things that you develop over time. Having cancer as a newborn, 6 months old, that's very rare. Usually when we get into the 12-month to 5-year-old age is when we start to detect those types of things. And you can detect it on physical exam. It's just an acute change in the patient's presentation. But things like I said, thalassemia and and other processes like sickle cell. We will generally detect those either when you're born on your newborn screen, and some things we can actually pick up prenatally when mom gets her genetic testing done. So amniocentesis and things of that nature. Those are mostly genetically identified. We can also detect them from a family history.
Okay.
So if we have a mother that has sickle cell disease, dad has sickle cell disease, there is 100% chance that their child will have sickle cell disease. Or if we have a mother that has sickle cell disease and dad has traits, or we don't know what dad has, then we can do some testing on the front end to just prepare the family for how to manage the patient on the back end.
Interesting. Okay. So we've had the testing, everything is clear. Now, baby Sarah, I'll just, give a name, baby Sarah, is now maybe 4 years old. And mom is seeing some things that might, she might say, she's not looking good, or maybe she's not as active as she used to be, or maybe her appetite has changed. What are some of the signs that something might be wrong, and you might want to check with the pediatrician or the family doctor?
Yes, I tell families all the time. So I think also you have to, again, break it into oncologic processes. So those are going to be your cancer, malignant processes, and your non-malignant. We call those benign processes. Benign is kind of a bad word because it can still cause issues, but it's not cancer. So that's why we call it a benign process. That doesn't mean it's any less impactful to your quality of life. So when we talk about malignant or oncologic processes, again, it's really going to be the trajectory of the child. Are they not behaving normally? Are they not acting normally? Parents will notice, decrease in activity. They'll notice increase in pallor, decrease in appetite. A lot of patients may have aches, fevers, bony pain. Those are things that we frequently see in pediatric cancers, leukemias, and solid tumors alike. Brain tumors, will often see kids start complaining of headache, which always makes parents nervous, especially if you live in the South, because springtime, everybody's got a little headache or a little earache because of seasonal allergies. But headaches that wake children up out of their sleep, changes in vision, their inability to walk straight. Again, it's you're veering off of your course of normal. And if Sarah's 4 years old, Sarah has been tracking along a normal pathway. So something that looks unusual. And I like to tell parents, when they first come and get a new diagnosis, they feel like they missed something. And generally, it does feel like these processes just kind of pop up overnight, or they're so innocuous. They're little bits and pieces along the way. Like, oh, yeah, they had a low grade temperature. I thought it was just a cold virus. They had this, that, and the other. So it's not always obvious and apparent that there's something wrong. It's usually accumulation of things. As far as patients with diseases that they were born with, so sickle cell disease, luckily for those patients, when we diagnose it at birth, we have the ability to really intervene before patients have any issues. Okay. So that's why I kind of split them into two. So things like thalassemia and sickle cell disease, we can mitigate any issues with them by giving them transfusions. Let's say for patients with thalassemia, if they need to have transfusions, we can support them with transfusions to make sure that they grow normally. Patients with sickle cell disease, we can start them on medications like hydroxyurea or folic acid to help support their blood development so that they don't have as many complications as they would without being on those medications. So it really is kind of determining whether if it's something you're born with, we can kind of intervene along the way, which is really the point of doing a newborn screen, is trying to prevent you from having complications sooner in life. Hopefully we can stay them off a little bit later in life, or you not have them at all. And then patients that come along with more acute issues later on in life, we do an intervention then.
So that is a lot. When you talk about for the patients that have sort of gone past and they now, they're exhibiting symptoms and they need to have a little bit more of, I don't want to say micromanagement, but they have to have a little bit more care. And it leads to a blood stem cell transplant. Can you talk about the two ways that the blood stem cells are collected,
Sure.
and then talk about the actual process of the
Sure.
transplant.
Sure. So there are two different ways that blood stem cells can be collected. The first way is extracting it from the bone marrow. So we often think about bone marrow in the South, or if you have parents that originated from the South, inside of the bone is the spongy material. I like to describe it as your soil for your garden. So your stem cells are basically seeds that go into the soil, they grow, and your bone marrow provides nutrients for those seeds to grow. And once you have cells that are mature enough, they go out into the periphery, they work, and when they finish their work, they're replaced by other cells. So it's this ongoing cycle. So the first way that we can get your blood stem cells is we can actually just extract the blood stem cells straight from the bone marrow. So it occurs in a sterile environment, often in an operating room or some type of procedural room that is sterile. And there are needles that we use to go into the larger bones of the body, and that's usually going to be the pelvis. So your pelvic bone, and we will pull with the needle. We'll pull out the liquid part of your bone marrow, and that has all of those really rich stem cells in there. The other way that we can do it is we can extract or siphon off your peripheral blood stem cells from your blood flowing around. That's a little bit of a different process because generally speaking, we may have to give you medication to force more of those cells out of your bone marrow into your periphery. So we'll use medication like G-CSF, which is a growth stimulating factor. And that makes your, I say it's genetically, when people talk about GMO and you get this increased production, so it forces basically your bone marrow to increase production of these stem cells, these peripheral blood stem cells.
Okay.
And then we use apheresis, which is what I do, to separate out those blood products, those stem cells, those blood stem cells from the rest of your blood, from the red cells, from the platelets, from the plasma. We collect those, and those are what are used to do a transplant later.
Is that done through a machine?
That is done through a machine. It is done through an apheresis machine.
I feel like it reminds me of being in science class in high school. And I think it was called, is it centrifuge?
Centrifuge.
Yes. I remember that.
That actually is the technology. So we will pull off whole blood. So most of us think about whole blood, we just see red. But from a transfusion medicine or a hematology perspective, we know that whole blood is made of particles and cells, and it's made of liquid. So your cells are floating around in this liquid, and there are lots of different types of cells. So what apheresis does is it centrifuges and spins the blood down, and your cells actually will layer themselves based on their specific gravity and their weight. So the machine is very smart. My nurses are even smarter, but they use a light that goes and says, okay, I would like to collect these stem cells, these peripheral blood stem cells, and then they'll siphon those off. And then we'll return back to you what we don't need. So it's a very specific process. We try to just collect what we need and give you back what we don't need.
So in essence, you're not losing blood. You're just losing stem cells because it basically comes out of one arm. It does what it needs to do, and then it goes back into the other arm.
Keep in mind, so your stem cells, your peripheral blood stem cells, and even your blood stem cells that come from your bone marrow, they do have blood in them. So it's going to be a bloody product, but it wouldn't be the same as, let's say, you're not being exsanguinated when we do the process. We make sure that it has not a lot of red cells in it, so that we can make sure that we maintain the integrity of the product and really get the stem cells.
But how long is the process?
So
I know it differs on average.
Oh, yes. So bone marrow collection. So when they're doing a blood stem cell collection from the bone marrow, that could probably take an hour or two.
Okay.
And that really just depends on how many blood stem cells you have in your bone marrow. If your bone marrow is really ripe and ready for harvest, it's not going to take long to do that collection. Or the alternative is if you have a donor who is bigger than the recipient, then you don't have to collect so much volume because you can get enough stem cells in a small volume from your big donor to cover your little recipient.
Gotcha.
Okay. And that's the same way in doing it in peripheral blood collection or apheresis. But that does take a little bit longer because everything's concentrated in your bone marrow. Things are not concentrated in your peripheral blood. So the process of pulling your blood out, centrifuging it down, siphoning off what we need, and giving it back to you. And then we do that process several times. Okay. So that process really depending on your stem cell number, your peripheral blood stem cell number prior to the procedure could take 2 hours, it could take 8 hours, and it could take several days of 8-hour collections to do. So it really just depends. Hopefully we get good counts so we don't have to keep a patient on the machine for a long time. But there are some situations, specifically patients that have sickle cell disease, and we'll talk about this a little bit later, who are getting gene therapy. And they only get a certain type of stimulation. It's not the best stimulation in the world, but it does cause their counts to go up a little bit. And so for patients with sickle cell disease, number one, because their counts are not that high, and we need such a large volume of blood stem cells to do their transplant, we will usually have to do their collection over several days, and then we'll have to do it in several sessions.
Okay. Well, with that amount of time and having to do it sort of in sessions, as you say, how many times can a person be a blood stem cell donor? Or is it recommended to be a blood stem cell donor?
That's an interesting question. I will be honest with you. If you are an autologous donor, meaning you are donating to yourself, I've actually never had a maximum number. That's an interesting question though, because I feel like you can donate to yourself as much as your bone marrow will allow you to donate to yourself.
Okay.
As far as allogeneic donors, so this is somebody who is not the person getting the transplant, donating to the recipient who is getting the transplant. I actually don't know how frequently they can do that. Keep in mind, though, transplants are based on your genetic match. So we do have situations where, for whatever reason, maybe a donor who is a great donor before is not available, or they're ineligible for one reason or another. Or perhaps after your transplant, you relapse and you've developed antibodies, and that makes maybe the donor you had before not eligible. So there are a variety of different reasons that people wouldn't donate several times. In siblings, when we have matched siblings, I've seen matched siblings donate several times, but I've really never seen it more than 2 or 3 times. I do want to take a moment to circle back to clarify, talking about the source of the blood stem cells.
Okay.
We did talk about how you could collect them from the bone marrow or you could collect them from the periphery. But I do want to clarify there are a variety of different human sources you can get them from.
Okay.
You can collect blood stem cells from yourself in certain disease processes. That would be considered autologous or an autologous blood stem cell collection. There's also getting blood stem cells from not you. So they can either be somebody who is related to you, oftentimes a sibling, maybe a parent or some other family member who has some genetic closeness to you. Or you can have a donor that is registered with NMDP who happens to be a close enough genetic match for you that they can be your donor. In those two situations, when they are not related to you, those would be considered allogeneic donors.
Absolutely. One of the things as you bring up the registry, and I know that we're coming to the close of the episode, and I thank you so much. All of this information has been amazing. What we know that for the blood stem cell donor registry, that there is a need for more African Americans to join the registry. What are some of the ways that you think, and in your profession as you see African American families and ethnic families, what are some of your thoughts on why we don't have as many African Americans on the registry, and how can we, in your opinion, get more African Americans to join the registry?
Sure. That's multifold, I think. I think the biggest one is just education. I think that we don't always talk about in spaces Number one, who is eligible to donate? Why would you need to donate? Often we think about organ transplant, solid organ transplant,
Yeah.
and people are very familiar with solid organ transplants. But when you start talking about blood stem cell transplant, that's a little less familiar to people. So I think more of it is really just getting it out there and having the conversation. Obviously, if you've had somebody that's had cancer, or if you've had somebody that's had a benign hematologic process that needed a blood stem cell transplant, then you're more familiar with it.
Okay.
So just making it more available, something that we talk about. And, honestly, the thing that we talk about often is trust in the medical system.
Mm-hmm.
I think that it's really important, number one, to have providers that look like they're patients that they're taking care of. There is a level of trust that is there when you have something in common with your provider, whether it's your gender identity, whether it's your ethnicity, your religion. There is a level of trust that is there when you have something in common with your provider. So, diversifying the provider population so that we can go into churches, we can go into synagogues, we can go into mosques, we can go into schools, we can go to Friday Night Lights. Football is very big down here in the South. Go to big places like that and really put the word out there and just stimulate people's curiosity, I think, because people will generally want to know what it's all about.
And we've seen that. We've gone into the communities and we'll get people that are interested and they will ask the questions. But it is also because they have not, or they're not familiar with us as much as we would like, or as much as they need to be to have that trust, as you talk about, right? So a lot of boots on the ground. We're making waves, and NMDP is committed to growing that registry and building that trust. So
that's fantastic.
Well, with that being said, I know we're at time, and this was so great. Like the information that you gave is just mind blowing. Like I love learning about this, and I hope my audience does too. And I'll give you 10 seconds. If you had to say something to someone about blood stem cell transplants or donations, what would it be?
I would say that it is life transforming for somebody who gets those stem cells. And just like I press upon people to donate blood products, platelets, red cells, please investigate donating blood stem cells. You can change somebody's life. You can save somebody's life by giving the gift of life and donating blood stem cells. So.
Well, with that being said, Dr. Margot Rollins, I thank you. I thank you for joining me today. I thank you for giving us all this amazing information. And I thank you for educating me so that I can continue to have the conversation as well.
And I'm grateful to be here. Thank you for having me.
Thank you. With that being said, we are at the close. It has been an amazing time. If you want to learn more about NMDP or any of our resources, please head over to www.nmdp.org. And until next time, remember, it will take all of us to save one of us.
Yes.
Bye.